What are the goals of therapy when you work out a treatment plan?
So they're different for different severity types. So for mild and moderate, it's still the standard is on-demand therapy because those patients tend to not have spontaneous bleeds. But there are clearly patients that are different, and it goes back to the mutation type. So about a third of the moderate patients, levels of 1 to 5%, are on regular preventive treatments. But the standard of care in severe hemophilia is prophylaxis. And what I mean by that is that means regular factor concentrate infusions to prevent bleeding.
Okay, in other words, I want to make this very clear.
Sure.
There are two treatments here. One,
Yes.
you're bleeding, let's stop it.
Yes, of
And
course.
the other is, how about we don't bleed at all?
Yeah, exactly. And so, so for severe, we want both of those goals, right? And so we are trying to prevent as much bleeding as we can, but kids fall and they trip and they hit their heads, and then you still need to treat for acute bleeding events. But in general, we tend to recommend most of the guidelines before age 3 and before the first joint bleed. It's recommended to start these regular factor infusions. But as you know, the limitations are starting an IV in a 2-year-old is not a simple task. So just think about it. You get up in the morning and you're trying to get your kids ready for school. Think about saying you got to get up. They might have to do some push-ups and get their veins ready, get them warmed up. You got to start an IV, infuse factor, and then get them ready for school. And so you can imagine doing that 3 times a week, 4 times a week.
That's a lot of impact.
That's tough on the kids. And then if you can't get it, the kids get really upset. And, obviously,
Sure.
It's very traumatizing.
There's something now called hemophilia treatment centers. Yes. How does that fit this whole model of preventing bleeding, and how do they fit in with what you do?
So another historical vignette, back in the 70s, companies were able to purify factor out of plasma. And they could dry this down, lyophilize it, put it in a vial, and ship it to anybody who needed it. And you could reconstitute it and infuse it intravenously. And patients were then freed from going to the hospital. They would get these products. They would learn to infuse themselves intravenously and do this at home.
Again, IV, not IM, not sub-Q.
IV. And that really prompted a whole wave through the federal government of starting comprehensive treatment centers.
Well, let me stop you because I'm a little confused. Yeah. If you can give somebody this drug to give to him or herself or with parents, what do you need a treatment center for?
So it's easier said than done. Diagnoses need to be made. Patients still bleed on this treatment. The difficulty with taking these proteins is they have a short half-life, which means when you infuse it, after a period of hours, a lot of that is gone and has to be re-administered. It's very difficult, especially in children, even in adults, to train them to do that. So they will still have bleeding episodes while they're getting treatment.
So what is, let's define it. What is an HTC, a hemophilia treatment center?
By definition, this is a mechanism, a grant-based mechanism from the federal government. The group is HRSA at HHS. And if you're an institution that has a grant mechanism with them, you are designated as an HTC, but this requires you to have nursing, physical therapists, social workers. Physicians actually are not mandated in this, which is kind of interesting. And it allows these groups scattered, I believe there's 130 or so now in the US, to obtain factor and dispense it to their patients.
For the average person with hemophilia, if there is such a thing, are these HTCs easy to get to? Are they accessible?
They're throughout the US, obviously in all major cities. They tend to be scattered. Patients are scattered where you would expect in the Midwest or the West. But they do exist in all states. And some patients have to take a subway ride for an hour to come to New York at our center, and some have to drive 3 or 4 hours to go to Iowa or out in Denver, that sort of thing.
We talked about pharmacologic approaches to this, at least in terms of clotting factors, but there are other things that we do too that are associated. I suppose you get them at the HTCs and elsewhere. The non-pharmacologic options and physical therapy, things like that. What do these involve?
So as I mentioned, despite the factor therapy, which has revolutionized treatment in this fatal disease, because kids, no one lived really past their second decade in life. With the advent of prophylaxis, they're still bleeding. That requires either orthopedic help, but we've found over decades that physical therapy, it used to be let the kids sit with ice and leave them alone. Now that's not true at all. Get them up, moving around, doing special exercises helps them tremendously. We even do ultrasound now in the clinics. That's now taken over. We can actually use ultrasound to detect problems in particular joints that patients have.
We got pain management issues.
Pain management is a massive problem. I was reared in this field when opiates were quite common and quite frankly, in my view, added a whole nother disease onto a disease. But it was mandated pretty much that aspirin or nonsteroidals or anything like that, which should not be used because they have effects on platelets.
Sure.
It was thought they would potentiate bleeding. Now we use these quite routinely in clinic. Pain issues now, because we are left with a cadre of young and older men, especially older men with all this joint arthritis, is now evolving in this field. It hasn't caught up anywhere to where we'd like it to be. We want to avoid opiates at all cost. But we go to pain meetings and whatever, there are a lot of drugs that, naltrexone we're trying to use in our clinic, drugs for fibromyalgia, seizure drugs, other modes of treatment. Right, but basically if you prevent bleeding and you prevent the arthritis, but that we haven't gotten to that point yet.
But I mean, that's the obviously gold standard, right?
Right.
No bleeding, no joint damage, no need for pain meds.
Right.
Everything comes with a cost, whether it's antiplatelets from the NSAIDs or it's the tolerance from the narcotics. It's tricky. What about dental work? These people do need dental work.
This group of patients, I have to admit, has probably the worst teeth I've ever seen. And why that is, I do not know, other than we see them on a routine basis. They constantly need dental work, and many dentists will avoid these patients at all costs because they just do not feel comfortable.
I was going to go there. That may be why they have terrible teeth. The dentist won't touch them. And when they do, they're afraid to do so.
At our center, most centers, we have dentists that are attuned to these patients, and we have methods to get them treated before and after any kind of dental work, and so that's really not much of an issue.
All right, well, I'm going to run down
That's
now.
another obvious benefit of HTC.